Hello everyone, and welcome to today's live broadcast, Radiomics, the Potential of Image-Based Phenotyping for Precision Medicine, presented by Dr. Hugo Aert. We're excited to bring you this educational web seminar presented by LabRoots. For more information, please visit labroots.com. My name is Soon Pham from LabRoots, and I'll be your moderator for today's event. Before we begin, I would like to remind everyone that this event is very interactive, and we encourage you to participate by submitting as many questions as you want at any time you want during the presentation. Just click on the green Q&A button located in the lower left-hand corner of your presentation window and type in your question into the box that appears on the screen. We'll answer as many questions as we can at the end of the presentation. Also, please notice that you will be viewing the presentation in the slide window. To enlarge this window, just click on the screen icon located at the lower right-hand corner. Finally, if you have trouble seeing or hearing this presentation, please click on the support button at the top right of the presentation window, or use the green Q&A button to let us know that you're having a problem. Now it's my pleasure to introduce our speaker, Dr. Hugo Aert. Dr. Aert is Director of the Computational Imaging and Bioinformatics Laboratory at the Harvard Dana-Farber Cancer Institute. Dr. Aert's group focuses on the development and application of advanced computational approaches applied to medical imaging data, pathology, and genomic data. Furthermore, he is a PI member of the Quantitative Imaging Network and the Informatics Technology for Cancer Research Initiative at the NIH. Please join me in welcoming Dr. Aert. I will now turn the presentation over to him.
Hello, thank you for the introduction. Indeed, my name is Hugo Aert. I'm from Harvard, Dana-Farber and Brigham. And I'm the head of a research lab that focuses on analysis of medical imaging data and seeing how this medical imaging data can potentially have a role also for precision medicine. So we're converting imaging data into quantitative data that we then can link to genomic and clinical outcome data. All right, so this presentation, I want to discuss I have three main objectives. The first one is to describe the motivation for computational imaging and radiomics. So why do we want to do this? What do we think is going to be the role in cancer research? Also, we'll describe a robust methodology. So how are we doing this? How we ensure that these biomarkers that we develop are robust, also across different centers and institutes. And also, I will give you at the end an example, some example studies that we have been doing in collaborators in radiomics and imaging-genomics, just to give you a flavor of the field. All right, so as everybody probably knows within cancer, cancer is not being cured. Despite the genomic era, we see that cancer deaths in the Western world at least stays very stable. So there's several factors of that, and of course now with immunotherapy and targeted therapies, there's a lot of breakthroughs that are expected. But one key aspect in cancer that's really one of the reasons that cancer is so difficultly treated is intra-tumor heterogeneity. So for the people outside of the cancer field, a tumor is not a homogeneous bulk, it's not a homogeneous disease. You're actually fighting multiple sub-regions within the tumor. And each of these is subclonal regions, they call this. And each of these likely will require a different strategy to cure them. So there's this study that is shown in the New England Journal of Medicine, which I think is really a groundbreaking study. It's already presented a couple of years ago. And this was done by Charlie Swanson from UCL, so University College in London. And what they did is in RCC, so in renal cell carcinoma, they took patient tumors out and they sequenced different regions from this tumor. So what they found was really staggering, is that there's a lot of shared mutations that occur across these different regions, but also is that there's a lot of mutations that are very unique to one specific subclone. So if there are targeted therapies that are directed at one of these mutations that occur only in a specific number of subclones, it's very unlikely the other subclones will be treated. So you could see, for example, a treatment effect, reducing certain subclones, although other subclones that are not being affected by that mutation will not be cured, and then will be dominant in a dominant phenotype and genotype in the future. So what they also did is that they they look at prognostic gene signatures. So they look at the gene expression data from each of these different subregions. And what they found is really amazing is that they found that for the genes that are in the signature, as you can see in the bottom here, the expression levels were even reversed. So this means that if you probe one area of the tumor, the prediction of the signature was, this patient is going to have a great survival. And if you probe the other part of the tumor, it will say this patient would have a very bad survival. So this really demonstrated, one of the key problems for target therapies, but also for biopsy-based assays, right? If you probe one area, do you get a comprehensive view of the tumor genotype? And also, what kind of consequence will this have then for precision medicine? So imaging in this area can really bring complementary data. So imaging for precision medicine, it has a lot of advantages. It's performed non-invasively, so you don't have any risk going in. There's for some like CT and PET, there's some radiation dose, but that's also low. The risks are pretty low. And the nice thing also, it really provides a 3D picture of the tumor. So you can really see the full cancer, the full 3D cancer in the complete volume. But also what is really important is that it's already performed in clinical practice. So there's a lot of data before treatment for diagnosis and staging, then during treatment, for example, for radiotherapy planning, and then also for response assessment. So what we can really see is we can really see a tumor evolving before, during, and after treatment. So we can really quantify this tumor phenotype. So we can really capture cancer's appearance over time and space. Of course, there's also disadvantages. We probe the cancer at a macroscopic level, not at a microscopic level, what we likely also want to see. But also, it's often very qualitative and not quantitative. So this means that the three-dimensional pixels, the voxels we call them, the exact values of these are difficult to compare between one patient and the other. And even if you want to compare a tumor over time, the different scans can have different values. So we are part also of the quantitative imaging network of the NCI that really tries to drill down to more quantitative data so that the data becomes more standardized and also more quantitative. All right, so what I show you here is probably the most important slide in my presentation. So this slide shows the CT imaging, which is really the workhorse in oncology, of 6 different lung cancer tumors. And what you can see here is that the imaging is shown on the left, and there's a 3D mesh shown on the right. And what I want to show you here is that there's a lot of phenotypic differences. So, some are very homogeneous, some are very heterogeneous, other ones are very round and isolated, other tumors are more spiky and infiltrated into the surrounding tissue. So there's a lot of phenotypic information that even non-experts can quantify from these imaging data. So, and remember that in the clinic for diagnosis and response assessments, only a maximum diameter is used. So they draw a line here and say, this tumor is 5 centimeters, discarding all other information, and another tumor that is like 8 centimeters. And then, based on that, there will be different diagnosis and also staging, but also response assessment. So there's much more phenotypic information that is already presented in these imaging data that we can also can extract. So one of our main reasons of what we do is we apply computational approaches to this imaging data and try to extract that phenotype. So it's really multi-level data. So if you go from different hierarchical levels, if you go from the top, you can see that there, we can have anatomical imaging like CT. You can also have like functional imaging with DC-MRI, for example. You can image metabolism. FDG PET, which is radio-labeled glucose, also gives you metabolism information. I can all the way go down to the genome level, which is also a form of imaging, to say it like that. So what we want to do is we want to convert this imaging cube, which is not comparable, which is not quantitative, into radiomics data using the approach I will show you later. And once we have that quantitative radiomics data, we want to link that back to genomic data and to clinical outcome data. So what we want to assess is what are the driving biological patterns, what are the driving biological pathways and mutations, for example, that drive a distinct phenotype. And also how can we use this phenotype data together with the genomic data to better predict clinical outcome. So there are 2 studies I really want to mention, which I think really set the scene for this research. And one study that was actually published in Nature Biotech already in 2007 by Aaron Segal. And what he did is he did very interestingly, in a liver cancer, they quantified 138 traits by imaging, like, textual heterogeneity, halos, internal arteries. And expert radiologists scored these. They say, like heterogeneity 1 to 5, or is there a halo? Yes, no. Or are there internal arteries? Say, no, a little bit, or high, for example. So they quantified these phenotypic traits by experts. Then they linked that back to genomic data, and they found that for several of these phenotype semantic features, as we call them, we found a very high correlation with the genomic data. And they could even predict 89 or 88% of the genetic heterogeneity. So they really showed a demonstration between the genotype and the phenotype. So the data, was a small data set. It was heavily undersampled for their tests. It was only 28 samples for training and 19 for validation. But I think they really, was more like a proof of principle study where they tried to combine both data types. From the same group, they did something similar in PNAS in 2008, and this was done in brain cancer. And they quantified phenotypic traits like contrast enhancement and mass effect, which were also, again, scored by radiologists. And they linked them back to genetic pathways like EGFR overexpression, hypoxia, and proliferation. We all know that are involved in treatment resistance. So again, they demonstrated this effect between the genotype and phenotype in GBM cancer in this case. And they had a smaller data set for training, but a larger data set for validation. All right, so we wanted to build on this. So that's also where the word radiomics comes from. So radiomics involves the extraction and quantification of automated features from images to produce data elements. So we want to automate that process. So we want to use advanced features to quantify these traits in these imaging data. And we try to provide an as comprehensive as possible quantification of the tumor phenotype. So we evaluate hundreds of features, and then using data, we drill down to the ones that we see are informative, and then we try to use independent validation sets to validate the performance. So there are roughly 4 steps. It's a little more complicated, but I think these 4 steps are the main 4 steps that are involved in these analyses. So first you have imaging. You have to take an image, of course, and how you acquire that image is all the settings and resolution and signal to noise ratio. All these aspects are very important. Once you have, once an image is acquired, you have to define segmentation. So you have to define what is a tumor area, for example, and what is the normal lungs, what is the heart. And once you have that, when you have to define this region of interest, there has to be some feature extraction. So then you extract features from this region of interest that quantify these phenotypic measures. And once you have these data, and we have now 1,600 different features, the analysis is very similar to a bioinformatics analysis. So you have to do feature selection, you have to drill down to the features that matter, and then you have to evaluate these with respect to other data types. So each of these steps also has its challenges. Of course, imaging data, how it's acquired, reconstruction, standardization, all of these different aspects are very important to and have to be addressed for really quantitative radiomics data. So also these segmentations, as described before, we have to ensure that these are accurate, but also we want to automate them. And the main reason we want to automate them is that once we have large data sets, say hundreds of patients, we want to go retrospectively back and analyze these patients. It will take a very long time to have expert radiologists segment them manually. It often takes years. So automated methods or semi-automated methods that could help in this whole process can be very informative and can really help the workflow of our analyses. But also, I think even more importantly, is that we want to use these semi-automated and automated techniques to really reduce the high intra- and inter-observer variability. So if you have 5 radiologists that segment the same tumor, all of them will have slightly different boundaries. So we want to, using semi-automated techniques and automated techniques, we really want to reduce this observer variation and hopefully get more stable results. So we're applying a lot of our techniques in the 3D from the 3D Slicer platform. So 3D Slicer is an open source imaging platform that's developed here at Brigham. There are several different algorithms for fast, semi-automated, and automated segmentation that are developed in there. What you can see here is a visual representation of a tumor that is in the upper lobe of the lung, and you can really see the 3-dimensional segmentation that we performed, and also the lung segmentation on the right. So once we use these automated techniques, and there's one region growing algorithm, for example, that's implemented to GrowCut, what we could see is that using these automated growing region algorithms, you could really find small extension, for example, in the phenotype, very small, small extensions in the tumor that normally are completely missed with manual segmentation. So on the top you can see this automatic one, and at the bottom you see the manual one, where you can really clearly see this slice-by-slice effect. So radiologist segments one slice and the other, and then the other. So and then never goes, often not goes back to the upper slide. So you can really see that manual segmentations often don't account for this full three-dimensional phenotype. All right, so once we have an image, we have a segmentation, we can extract different features from it. So we have to define features, we have to see which ones are informative, which ones are reproducible, which ones are robust. So we have our current release accounts for 1,600 different features. And so what we do is we quantify various aspects of the phenotype. So at the top, you can see different shape-based features, which quantify roundness and spikiness of the tumor, for example. And these can be very simple algorithms where you calculate the surface area divided by the volume, for example. But this can also be way more complex, where you quantify different frequency patterns on the surface area, for example. We also have textual features, and we see this is by far the largest group of features that we assess. What we use there is different algorithms that were developed in computer vision and AI, where we quantify different textual patterns. So the gray level concurrence matrix is a matrix that quantifies, to say it simply, differences between adjacent voxels. It looks more at heterogeneity, and the gray level run length matrix looks more at homogeneity. So how often is a run length, so how often is a certain value the same across the tumor. So you can quantify homogeneity and heterogeneity with these. Even first order statistics can be important, like quantifying aspects like entropy, or even range or max or median density, for example, with CT imaging can be very important. But also, we transform these images into another frequency domain, and we apply different filtering techniques, like the wavelet filtering and the Laplacian of Gaussian. And once we do that, we again can extract different textual features, similar textual features that are shown on the left. We can again extract from these different filtered images. So all in all, this gives a feature set of over 1,600 features at this moment. Of course, once we have all these features, we have to select the right ones, right? And we have to apply different machine learning techniques to this, and we have to see, which features matter. So the motivation for this is, if we want to build accurate and reliable and efficient biomarkers, radiomic-based biomarkers, we really have to use machine learning methods. And of course, radiomics really suffers from the curse of dimensionality, so we have a lot of data for a limited number of samples often. So there's a need for feature selection, and also we see that these machine learning and more modern feature selection methods really derive better models than if you compare them to, say, standard statistical methods. So what I want to show you here is this is a very simple correlation heat map. So in both directions, in the vertical and the horizontal directions, you can see the radiomics features, and we just wanted to see, how highly are they correlated. And what you can see immediately is that there are a large number of features that are very highly positively or negatively correlated. So that's also one of the reasons we really have to reduce this dimensionality. So there's a lot of redundancy in the data that we have to reduce. So the nice thing actually is that once we want to reduce this dimensionality, we have access to different data sets, which are not that common, for example, in genomics. So one data set which I really like and we use a lot in our analyses is the WIDA test retest. And this is a data set that was developed at Columbia University by Larry Schwartz's group. And what they did is they took CT images of 31 non-small cell lung cancer patients. So they acquired a scan for 31 patients. The patient got off of the table. It's called a coffee break test, so likely they got a coffee. They went back 15 minutes later and they got another CT scan. So what we then did is we had these two scans available for the patient, and then we segmented both and we calculated features. So what we could do by this is we could say from all the features that we have, if they're not stable within 15 minutes, it's going to be very unlikely that they're going to be informative or robust. So we could remove them. And also, the ones that are more stable, we don't know if they are going to be informative, but at least they're stable. So by using such method as this, we can really get rid of non-robust and non-stable features. Then another way of doing this, we can also apply some machine learning techniques. So one study that's done by Shinton Palmer, so he's a machine learning expert in my group, where he assessed different machine learning methods and radiomics data. So we had a training data of 310 patients and an independent validation cohort from a different institution of 154 patients. And so from both data sets, we extracted features. Then we did a machine learning data and the training. We had different radiomics methods that we evaluated, and we linked it back to clinical outcome, so to survival data, to see how prognostic these biomarkers were, and also which method works best. So once we have defined these biomarkers, only these biomarkers were applied to the validation data set, and the performance was assessed independently. And this is actually the main results. I don't want to show you too much about the results, but just to get a flavor, so in the horizontal direction, you can see different machine learning classification methods, and in the vertical directions, you can see different feature selection methods. And what is really interesting here is that you can really see that certain combinations of classifiers with feature selection methods work really well, and others don't. So often in a publication, they choose one, and it's unknown why that one was chosen. But it's often very unlikely if chosen the most optimal one for this problem. So one, for example, that we use a lot is MRMR, which is maximum relevance minimal redundancy feature selection. And we try to use that, for example, using support vector machines or other random forest, for example, classifiers. And we see that really works well, and also now we are using these techniques well. So another way of doing it is also looking at the stability of these feature selection methods. So we can assess on the left, we can assess the performance, for example, of these different feature selection, also stability. So how robust are these against perturbations of the data? How robust and how often are the feature selection and classification method, how often do they derive to a very stable result? And likely a stable result is also going to be more translatable into future clinical studies. So by doing so, we did these analyses, and you can see here in the gray boxes, for example, there are feature selection methods which are really stable and classification methods which are really stable. And that's also something that's really important. There's always a trade-off for optimal performance versus stability. And often we have to find a good combination of these, which often are not the most high performance, and at least in these data sets we're assessing, but at least we find that they're the most stable methods that we're finding in these data sets we're evaluating. Of course, we can also do some ANOVA. We're looking at variance, and what you can see here is that the different factors that are important, for example, for these classifiers. And we see, for example, that the classification method is really important. So which classification method you select for radiomics analysis is really important. The feature selection method is less important, and the size even is also less important. So by doing these analyses, we can get a good idea, what kind of experimental settings affect our stability of our radiomics biomarkers. So if we then go to so once we have imaging data, we have segmentations, then we extracted features, and now I want to give you some example analysis that we have done at Radiomics and Imaging-Genomics. So one study that we published in 2014, this is a study published in Nature Communications, where we did a radiomics analysis of over 1,000 patients with lung or head and neck cancer. So what you can see in the figure, it was a very similar setup. So we used the imaging data. Then we did a feature extraction, and then we linked these radiomics features together with gene expression data and clinical data. So our main aim was to develop and validate a prognostic radiomic signature, and also we wanted to see if we have a prognostic signature in lung cancer, could we apply that to head and neck cancer. For a subset of these patients, we also had gene expression data, and we wanted to assess the correlations between the radiomics and genomics data. So this was one training cohort that we used of 422 non-small cell lung cancer patients that were treated at Master Clinic. So this is a clinic in the Netherlands. And what you can see here in the vertical direction are the radiomics features, and the horizontal direction are the patients. And you can immediately see that there are different subclusters of patients that have more or less similar expression patterns for the features. And also, if you define these clusters and link them back to different like T stage or N stage or overall stage, we could find very significant correlations between these clinical parameters and also, for example, histology. So we saw that there were differences in histology for these different features. But what you can also see in the vertical direction is that there's a lot of redundancy in these features, right? So you see a lot of features have more or less the same expression pattern across these 400 patients. So therefore, this again shows the importance of reducing this feature space. And what we often see is that we can quantify, say, 15, 16 distinct traits per cancer type and also per clinical problem. So lung cancer, for example, with CT imaging, we see different, say, somewhere between 15 and 20 different distinct traits that we can quantify. If we go more, often these traits become more correlated with, or combinations of the other ones. So what we then did is we also performed a relatively complex setup where we defined 440 radiomics features. Then we used this test-retest as described before to define a stability rank. So we did a rank for each feature, how more or less stable they were. Then we had also multiple delineations where we assessed stability for delineation, and we had a similar stability rank there. And then we had the lung 1 data set, which was the blue one, which was a training cohort of 422 patients, where we also had prognostic survival outcome. So using a relatively simple setup, we built a prognostic signature, incorporating the stability ranks and also developing this based on this lung 1 cohort. And the signature was based on statistics energy, so the energy of the total 3D volume, shape compactness, so how compact was the shape, and also most importantly, two features that quantify heterogeneity, so the gray level non-uniformity and the wavelet gray level non-uniformity. And we also found that these two features really were driving the signature, that were the most important of these in this signature. So then once we had this signature, we applied this to independent validation cohorts, and we did this both in lung cancer, so we had the blue lung 2 data set, of 225 patients from an independent institute where we could validate the prognostic performance of this model for lung cancer. But also we wanted to see, as this was a CT intra-tumor heterogeneity marker, was this also prognostic in head and neck cancer patients? And we had done 2 independent cohorts, one from Master Clinic and one from the Free University in Amsterdam, where we had head and neck cancer patients where we also had prognostic information and radiomics data available. And then we used the lung 3 cohort, which was a cohort where we had radiomics features and also gene expression data to assess the association of the signature with underlying gene expression patterns. So in total, we used over 1,000 patients for this analysis. All right, here I want to show you some Kaplan-Meier curve. So what you can see in black is a training AUC of the signature, and also in red there's the validation AUC. And what you can see clearly is that this performance, the model had a strong performance of 65, concordance index, which is similar to an AUC, of 65 in the independent validation data set. Then we also applied the signature to the 2 head and neck cancer data sets, and we found that the performance was even higher. So the concordance index was around 70 for both data sets that were independent. And we think that the main reason that the signature performed better and higher in head and neck cancer cohorts is that because these, with lung cancer, you always have movement artifacts from respiration and movement. With head and neck, they could fixate the head and neck before they take a scan. So therefore, it's likely they're going to be, less likely there's going to be movement artifacts. So therefore, we think that the signature performs better. We're also now trying to, looking at 4D information, so trying to get rid of these respiration artifacts in lung cancer and see by doing so if we can improve this prognostic model or not. Also, we compared on this radiomic signature and we compared it to different clinical parameters, and we found that the signature performed significantly better compared to volume. So, we could extract more phenotypic information than just simple volume. This is always our baseline that we have to assess. But also, we found that the combination of volume of this radiomic signature with TNAM staging always showed a significant improvement in all data sets. So you could really show that, and TNAM staging, of course, is the most important one. So we can really show it here and demonstrate it that there's more than that we can capture in this radiomic phenotype data that was complementary to the standard clinical parameters. All right, so what we then did is, so we had this signature which was developed years ago, right? So we took that signature and went to Princess Margaret Hospital in Toronto, and we used we had a data set, access to a data set of over 500 patients also with head and neck cancer. And again there, without going too much in detail, we really showed again that the signature had a significantly prognostic performance and also outperformed the standard metrics, really demonstrating the robustness of this radiomic signature. And so we compared it in all the complete data set, and it has a performance of 63. And then we removed the patients that have very strong artifacts, which means dental implants, for example, they give it large artifacts in the CT images, and if we remove them, we saw even that the performance went up to 65, which was really comparable to our previous result. So here we saw really the reproducibility of this signature across different data sets. All right, so what we did next is we investigated for these four features that were in the signature. We want to see how are they correlated with different gene expression patterns. And what we found is that statistics total energy and shape compactness, they were significantly associated with some tissue development gene sets. But most importantly, the gray level non-uniformity and the wavelet gray level non-uniformity, so really the drivers of the signature that quantified intra-tumor heterogeneity, were very strongly correlated with cell cycling and proliferation. So this means that if you see a more heterogeneous tumor on a CT scan, it's very likely you have an upregulation of cell cycling and proliferation. If it's a more homogeneous tumor, it's also likely you will have a downregulation of these pathways. So we could also again assess here this genotype-phenotype interaction. All right, so what we then did is we tried to build on these results and to really perform a large-scale analysis of imaging genomics and lung cancer. So we tried to uncover connections between radiomics data, molecular pathways, and clinical outcomes. But also we want to see, can we predict the state of a pathway by radiomics data? So can we predict important pathways that could be potentially important for precision medicine using this phenotype radiomics data. But also we wanted to assess the prognostic value of combining radiomics with genomic and clinical information and see if there was complementary information. So we had two data sets for this. So we had a discovery data set of 262 patients which were treated at the Moffitt Cancer Center. And for each of these patients, we had diagnostic imaging, gene expression data, and clinical outcome data available. Then we had an independent validation data set for patients that were treated with surgery at the Maastricht University Medical Center in the Netherlands. And for all of these, we also had diagnostic imaging, gene expression, and clinical outcome. And we use this as an independent validation data set. So we used a very similar setup. So in the top you have an image, we perform segmentation, we did a feature extraction, and then we did a data integration where we combined radiomics data with genomic data and clinical outcome data. So we had data set one, the Moffitt data set, where we had radiomics and genomic data of 262 patients. And we did a gene set enrichment analysis using biclustering to find the strongest associations between the radiomics features and the different pathways. So we wanted to see which groups of radiomics features were strongly associated and significantly associated with groups of pathway status. So what were the strongest modules of these association modules? Once we had identified these 13 main signals in the data, the main associations in this data, we validated these modules with association to clinical data. And for the majority of these patients, so 224 patients, we had also clinical outcome data available, so we could really see how are these radiomics genotype pathway modules associated with different clinical parameters. And then the nice thing is with our validation cohort, we could validate each of these steps independently. So we could see, are indeed these modules significantly distinct from background also in this independent validation data set to investigate if this was really a true signal, but also we could validate then also the clinical associations there. And this is the most important result that we have shown. And so what these are 13 different association modules that we are identified in this data and also independently validated in the validation data set. Where we use some robust statistics using perturbation to make sure that that was really significantly distinct from background. And what you can see here is that these radiomics modules were really associated with distinct biological processes. So this means that certain groups of radiomics features were associated, for example, with immune system or p53 pathways. Other ones were, for example, with TGF-beta or circadian clock pathways. So we really demonstrated that different features quantify different biological patterns and were associated with different biological patterns that were discovered and also independently validated. And also we found that these modules were significantly associated with distinct clinical parameters. So 3 of the modules were associated with survival, 5 of them with histology, and a large majority, 10 of them were affected by stage. So one of example is the module number 13, which was an ablation of Gaussian entropy features, which were significantly associated with the mitochondria. And then also another one was, for example, the circadian clock wavelet textual features, where there was a large number of wavelet features that were associated with important pathways that were involved in the circadian clock. And I think the most interesting results that we found was where we found the radiomics, different radiomics, also a large panel of radiomics features that were significantly correlated with the immune system and p53 pathways. And the nice thing is also we correlated this back to survival data, and we can find also that this module is really significantly prognostic. So by doing so, we can again investigate this triangle between driving biological pathways that could drive a radiomics phenotype and also clinical outcome, and see how this was how these were associated. Then very interestingly, what we did afterwards, we assess also, how are clinical radiomics and genomics data, do they contain, for example, complementary information to predict survival? So what we did is we took a genomic signature that was developed by another group in 2010 specific for lung cancer, which was 70 genes, so contained only 17 genes for post-treatment survival. Then we took our radiomic signature that we developed in 2014, but was never seen in this data, and we evaluated the complementary effects. And what you can see here, we also built a clinical model which has a very strong performance, which is also known. And then the genomic model was performing a little bit less on its own, and the radiomics performance was also significantly performance from random. So what we then did is we combined these. So we could really see, for example, that if you added radiomics with clinical, you had a slight increase, which was also not significant. But if you, for example, combine clinical and genomics, it really went up. But the most important thing is that if you combine clinical data, genomic data, and radiomics data, you had the highest performance. So this was also a significant difference in an independent validation data set. So really, we showed here the difference, the different complementary value of clinical radiomics and genomic data. And to show the reproducibility of our results, we also built other signatures, and we used other genomic signatures and other radiomic signatures that we evaluated these all in the training data set, and then went to the independent validation data set, and we saw a very similar pattern. So combining clinical genomics and radiomics phenotype data resulted in the best prognostic signatures in this case. All right, so now going to GBM, so brain tumors. What you can see here is that these are assessed often with MRI data. So the T1 contrast enhancement, they assess it, and with the FLAIR imaging. And what you can see here is that there is several phenotypic differences that you can immediately spot. So you can see, for example, on the left you see necrosis. So some tumors have a large chunk of necrosis, which is a black area in the tumor, and other ones have, for example, a very low number of necrotic core, for example, which you can see in the bottom. Similarly, like contrast enhancement, some have a very high contrast enhancement, other ones have a very low contrast enhancement. Edema, which is quantified by the FLAIR, you see some tumors have like almost no edema, other ones are really infiltrated into the surrounding tissue, but large regions. But also assessing the tumor bulk, you can already also see differences. Some are more homogeneous, other ones are very heterogeneous. So we see again that there's a lot of phenotypic differences that you can see. They can quantify using MRI data in brain cancer. And we use a setup, and I won't go in detail, but we use a manual slice-by-slice contouring by expert radiologists, and all these segmented different regions were approved using a semi-automatic technique, and were edited and approved by expert neuroradiologists. So at the end, we're relatively certain that we have a stable volumetric measures that we quantify. So if we then look at these volumes, we can already look at the prognostic value. We can say, for example, which ones are prognostic. And we can see, for example, the simple volumetric measure like necrosis, how large is the necrotic area, how large is the contrast enhancement area, for example, or the tumor bulk. These features are significantly prognostic already to predict overall survival. Other ones weren't. For example, edema. So the size of the edema was almost random, which was actually a new result that we found. Also we investigated then, what are the different genomic data. So we used 96 patients that were also in the TCGA, where we had also gene expression data. And what we did is we correlated these with these volumetric measures. What's very interestingly, what we found is, for example, that the necrosis and tumor bulk signatures were significantly correlated with immune response and inflammation pathways. But other pathways are like cell cycling, for example, were not significantly correlated with these, but were very significantly associated, for example, with this edema volume. So you can really see that the volumetric makeup buildup of a tumor really is associated with distinct phenotypic processes that each drive, or genotypic processes that each drive different volumetric measures. What we also did is we looked at different mutational data, again, in almost 80 patients from the TCGA. We had also some mutational data available. And we found, for example, that P53 positive mutated tumors had significantly smaller contrast enhancement volumes, for example, compared to wild type. And also, if we did this also on a larger scale, we found that these volumetric buildup of the tumors were associated with distinct genotypic mutations. So, for example, P53 mutations were significantly associated with contrast enhancement, and for example, the necrotic to contrast enhancing area, which is a volume ratio, was significantly correlated with EGFR, but not with, for example, with P53. So you could really see here that different mutations drive distinct volumetric buildup of these GBM tumors on MRI. All right. So I think I'm almost done. So this is, the current status of radiomics. So we really see that imaging moves more and more towards a computational data science. The imaging community can really learn a lot also, I think, from the bioinformatics community with sharing of code and sharing of data, which is almost never done now in the imaging community, although the last couple of years it's getting better. But also, due to advances in imaging, the scanners get better, the protocols get more standardized. Now the data that's being generated in more modern hospitals, to say it, we can really extract quantitative data from this imaging data. So that has a huge retrospective and prospective potential, right? So we can really mine all these databases that are generated in the radiology departments, and we can investigate these associations. We have defined a large number of imaging features, and others have done the same. We have implemented these in Python and MATLAB, and we'll release a toolbox soon. Was also incorporated in a 3D slicer that includes the most important radiomics features that we found. And also, we found that radiomic signatures are really prognostic across cancer types. We see that they're in brain cancer, and head and neck cancer, lung cancer, for example. But also, we see that the radiomics data is really strongly associated with the genomic patterns, which really demonstrate this genotype-phenotype interactions. But also, we see that we need to really drill down to robust biomarkers. We need to integrate different data sets, a large number of data sets from different institutions, to really derive robust biomarkers that potentially, eventually, could be used for precision medicine in the future. So the challenges that have to be addressed by the field now is that we have to further optimize imaging quality. We only expect that the performance of these biomarkers will only go up if the standardization is better. We have to develop better segmentation algorithms that are very accurate and robust and fast as well, so that they can be used by expert radiologists. But also we have to define radiomics feature algorithms that have a high performance and stability. But what is also very important is that we have to see how radiomics data, how these radiomics biomarker, what the exact role is going to be in precision medicine. So, how do we improve diagnostic and prognostic and predictive power? This will be different for each different setting. If you want to look, for example, at predicting drug response, You will need a different biomarker and different methodology, for example, if you want to look at screening data. But also, no matter what we do, we need very large data sets for discovery and validation to really drill down to biomarkers that matter. And one downside, actually, or challenge, is that it's very multidisciplinary. So we need, for these analysis, we need to work with radiologists, with medical oncologists, we work with radiation oncologists, computer scientists, with engineers, with medical physicists. So it always requires a lot of people, which makes it often not easier. And also there's some informatics challenges. We see that a lot of people are developing different code bases within their own laboratory. They don't share code, or the code is not available, not reproducible. So you don't know exactly how is feature entropy, even something very simple first order. We see differences, in different implementations, which means that we have to move more and more to technical developments which are better standardized. And also we see that there's a lot of analyses that are focused on a single disease type or imaging modality, and a lot of the methods and code could also be potentially used more broader across different imaging modalities and different disease sets. All right, so I want to thank you. I want to thank the people from my lab and from other people from Dana-Farber and Brigham. I also want to thank the people from Mayo Clinic in the Netherlands, from the Moffitt Cancer Center in Florida, and from Princess Margaret Hospital in Toronto. So thank you.
Well, thank you, Dr. Ayer, for that informative presentation. It was really, really excellent. It's now time for the question and answer session. So if you have a question you'd like to ask Dr. Ayer, please do so now. Just click on the green Q&A button at the lower left of the presentation window and type in your question in the box that appears on your screen and click the send button. We'll answer as many of your questions as we have time for today. So let's get started. The first question we have comes from Tammy, who asks, are there differences in the surface in tumors that have metastasized compared to non-metastatic tumors?
So that is actually a very excellent question. Oh, sorry. So I think that is really an excellent question. So we didn't see that yet, although we found that there's several shape-based features that were indeed associated with distant mets. So we can see, like for patients that were treated curatively with stage 2 or 3 lung cancer, for example, that didn't have any distant mets, we found that certain radiomics biomarkers were associated with developing of different metastases in the future. We still need larger data sets. It was only 150 patients that we had data on, but we are now collecting data sets where we can really drill down and answer these questions. But that is a very important question.
Okay, thank you for that. So now, while we're waiting for some more questions to come in, I'd like to ask a question, if I may. If you could comment on the prospects of, I guess, radiomics in the next 5 years or so. What do you think will happen in the field as a whole, and what do you have planned for your lab in this field?
So that is a great question as well. So I think we see now that this data type, that this phenotype data has promise for within the whole cancer precision medicine arena. So what we try to do now is we have to drill down to see what really matters. And if you, for example, we see now that we can predict EGFR mutation status with a high accuracy in lung cancer patients. But we work here with a lot of medical oncologists at Dana-Farber, and it's very unlikely that that they will trust a biomarker unless we have an AUC of, say, 98%, right? Because that is like the ballpark where these biopsy-based assays are. So the thing is, we'll never replace biopsy-based assays, but we could potentially provide a complementary role in precision medicine, as we can monitor this phenotype, for example, phenotype changes over time. So if you see, for example, that a tumor that was a diagnosis, had a low heterogeneity, but during treatment it develops this heterogeneity, it can be very interesting to say, hey, maybe in this patient, which was EGFR negative before, maybe probe again, because potentially it could be EGFR positive at this moment. So we have to define this rule. We have to see how what the rule is. But I think also with for these different drug for evaluating different drug response is that what a lot of drug companies see, for example, is that they have large data sets and they have targeted agents for, say, for example, the EGFR-mediated gene, and they see, for example, that 90% or 85% of all the patients that have that mutation that are very responsive to the drug treatment. So that's great. But also from the EGFR negative cohort, for example, they see that also like 15 or 20% of these are also have a very strong, also have a benefit for this treatment. So if, for example, the imaging data, the phenotype data could predict the ones that are EGFR negative, say, also based on intra-tumor heterogeneity, for example, and we can, I think it's also even good for to get these drugs and also potentially could evaluate these in these patients as well. So, the different roles that we have to discover, it's something that requires a lot of work. There's also we need very good data sets for this as well. The downside is that often these data sets in drug trials, for example, were not designed for these quantitative radiomics analysis. So the data quality itself is lower than if you do a prospective imaging study. So in that aspect, we are investigating this, and this is also something that we'll focus on for the next, say, 5 to 10 years.
That was great. Thank you for that answer. Next, we have a question from Edwin, who asks, which biophotonic tools look promising for this research?
So I actually don't completely understand the question here. So certain biophotonic tools could potentially be used for the radiomics analysis. So the big question, of course, is always, what is the quality of the data that we can use? So we didn't assess this. We are, that's something that we're also potentially want to explore in the future. But the different data will also be, the quality of the data will also really determine if we can do something with it. For example, if the quality is relatively low, for example, in ultrasound imaging, clinical imaging, we see that the radiomics performance doesn't really add anything to the standard clinical parameters. So we have to be very careful what data there is and what data we can use, and also the quality of the data to assess it. And that's something that I'm not certain of that biophotonic tools will be used. But it's something that we are for sure have to be investigating in the future.
Okay, great. Next, we have a question from Zev, who's at the New York College of Pediatric Medicine. And he asks, have you ever looked at correlations with immunohistochemistry data, as well as FISH and CIS data? And do you find or anticipate added diagnostic strength with these types of data?
Yes, that is also a very interesting question. That is something that we're actively exploring at the moment. So you want to see, what are the differences? What data can we extract, for example, from immunohistochemistry? That look at, for example, the buildup of these cells in different areas, and we can do similar analysis with extracting different features. So we're working closely with a laboratory from Andy Beck from Beth Israel, who's also here in Boston. And so we try really to extract a large number of data from the pathology and then see how we can link that back to the imaging data. So I expect, it will be very interesting to see how this different hierarchical levels also within the imaging data are correlated. Is imaging heterogeneity also correlated with heterogeneity that we see at a pathology level? And also, how is this heterogeneity? Because we can really drill down there as well. So something that we expect, our hypothesis is that there will be complementary value. We don't have a lot of proof yet, so we're really actively exploring this.
Okay, thank you. Okay, if there are no more questions, I would like once again thank Dr. Aert for his presentation. Do you have any final comments for us before we go?
So thank you. Thank you for being here. Please let me know if anybody wants to learn more about this research. Just contact me. Yeah, thank you for listening to me for 45 minutes.
Well, it was a wonderful presentation, and thank you once again for joining us today. So before we go, I want to let everyone know that today's webcast will be available for on-demand viewing until November of 2016. You will receive an email from LabRoots alerting you when this webcast is available for a replay, and we invite you to share that announcement with your colleagues who may have missed today's live event. That's all we have for now, and we hope to see you again next time. Bye-bye.